Right, okay, well, tonight's speaker, Alasdair Rooney of Good Parentage, came to Kerry at the start of S3 and went from Webster's down to the University of Dundee, where he eventually qualified as a doctor, specialising in psychiatry. And I reckon he's had 3 strands to his career so far. Well, he's had 4. The first one was being expensive. He once told me that he wouldn't buy a bottle of wine for less than £4. And I pointed out to him that with 3 boys at uni, I couldn't buy a bottle of wine over £4. That was a long time ago. Anyway, he did psychiatry in general and then went into research and did research into depression in folk with brain tumours. And I saw one of his talks, which was, of course I'm depressed, I've got a brain tumour. And then he's done research into the effects of electric shock therapy on mice, 2 on mice. And he's just moving now, he's just been appointed as a consultant neuropsychiatrist at the Scottish Brain Injury Centre in Edinburgh. So after that glowing talk, your talk bit, your introduction, your talk better not be crap.
Thank you for such a wonderful introduction, Dan.
You're welcome.
I'm sorry that it all goes downhill from here. Yeah, the ECT stuff, I'd be more than happy, by the way, to come and talk about that too. That is really, really cool. We've got some really cool results as well, but I'll leave it for now, park it for now. I'm going to share my screen and talk about something very different just now. So can everybody see
You're not sharing it yet.
that I'm bringing up? Can people see those slides?
I can just see my screen.
It says I am screen sharing the combination of post-traumatic stress disorder and coronavirus, the COVID-19 pandemic. So what I'm going to do, this is a fairly short talk on the grounds that no one was ever criticised for giving a talk that was too short. And I've kept it fairly general, but I'd be more than happy to answer any questions at the end. And the outline is simply, in 4 parts, I'm going to talk a little about what PTSD is, then just a slide on the kind of symptoms that people with PTSD might talk about or complain of. Just think a little bit about whether everybody gets it or not. And then moving on to think about how those earlier slides link into the experience of having coronavirus. So PTSD is an acronym that stands for post-traumatic stress disorder. And that phrase, post-traumatic stress disorder, can be broken down, which basically tells you what the condition is. It's post-traumatic, so it happens after an experience that is overwhelmingly frightening and beyond our control. So that may be physical trauma or it may be emotional trauma. It involves stress, so there's a severe emotional reaction which comes on after that traumatic experience. And it's a disorder in the sense that it interferes significantly with daily life. It's not just a normal reaction which will gradually go away. People get stuck in the setting of stress and it can wreak havoc with their lives and really impair them to a great deal. You know, they won't go back to work, they have a whole heap of other problems and so on. So it's a relatively new concept, PTSD. I say relatively new. If we go back 100 years, it was not recognised. And the classic example of this is a man who you may or may not have heard of before, called Herbert Burden. And Herbert Burden was the youngest man shot for desertion in the British Army during World War I. And he was 16 when he joined, if that. And he was at the Battle of Ypres in a place called Bellevarde Ridge. And after the battle, the landscape is shown as it was after that battle. So an awful experience. You just need to look at the trees. And he was hospitalized, and then he was discharged and sent back to the front, but he went missing, and he was eventually tracked down in another unit in a nearby town. Now, he said that he'd gone there because he'd heard that one of his brothers had been killed, and he wanted to see if it was true. But the army shot him 2 days later for desertion. And his figure is represented in the Shot at Dawn Memorial in England, where his statue can be seen in front of over 300 wooden posts who represent the 300 plus soldiers who were shot for desertion. Now, in 2006, the Defence Secretary for Labour, who you can see in the bottom right, pardoned him and these other 300 men because they had recognised that while it's very difficult to be sure looking back, it's probable that many of them had shell shock, which we now call post-traumatic stress disorder. Now, we can't be sure that this young man had PTSD. He also had a bit, I think, looking into it, he had a bit of a bad disciplinary record anyway, but he is emblematic of the idea that when men and humans are put under a great deal of stress, they can have emotional reactions which were not understood in the past to the extent that they are now. Whether that's right or wrong is a completely different debate, but it is the way that things are. And I think it sort of humanises the topic, because many people are discharged from the army now with post-traumatic stress symptoms. So what are those symptoms? Well, the classical combination is what's called hyperarousal, which is essentially just being completely vigilant, switched on, very anxious, psychologically aroused, unable to relax, always on your guard. Plus intrusions, and intrusions are thoughts which come into your head when you don't want them to come in. You've got no control over it, they just appear. And here in this list, they would be characterized by such things as flashbacks and nightmares. And the third element of a diagnosis of post-traumatic stress disorder is avoidance. In other words, making sure, or at least taking steps to make sure that you are not in the same position again, or in situations that remind you of that position. So for instance, if one is in a car crash and has post-traumatic stress symptoms after that, then you might avoid the street where the crash happened, for instance. And sometimes that's easy if you never have to drive there anyway, but sometimes it could be very difficult for your life if it was somewhere that you normally had to be. And so when we're talking to people with these kind of symptoms, we weigh it up and we think, look, is this really over the line for being a disorder? Or are you going through what we would call an understandable reaction and we think it will gradually get better? And that's part of the judgment of clinical psychiatry. Unfortunately, we have no tests that will tell you for certain if you have psychiatric diseases, or not many tests that will tell you of that. There are some, but this isn't one of them. And it's a problem because it also, as well as being inherently unpleasant and getting in the way of your work and your family life, and you're not as good a partner, you may turn to drink to numb the pain, because emotional numbing is also part of the syndrome. People won't let themselves feel that level of anxiety and arousal because it's unpleasant. You might become depressed. You might attempt on your own life. So this is a very difficult situation, and it really all boils down to an extreme reaction to stress. Now, I think it's worth asking, why do we have any kind of reaction to stress? It's pretty nasty, isn't it? It's not that nice. And I'm not talking about the stress of having a bad day. I'm talking about the stress of having your life under threat in some way or another, or severe and sustained emotional abuse. And I think it helps to think about it in evolutionary terms. If we imagine this little band of ancient rodents long before humans ever existed, and some of them are very fearful naturally and tend to run away at the slightest drop of a hat, and others are absolutely fearless. Now, if those animals encountered a T-Rex and all escaped, the ones who were fearful would not go back to that situation, and they would be relatively safer than the fearless animals that would blunder into the T-Rex's nest the very next night because they had no sense that it was a dangerous situation. And when that happens, the fearless animals are removed from the evolutionary chain, and the fearful ones remain. And if that's repeated over 100 million years, you end up with evolutionary ancestors that descend into humans where the thing that kept them alive was running away from danger. So we are all naturally fearful to a greater extent or a lesser extent. And so we all have stress reactions when we're under difficult circumstances. It's something that's just bred into us by evolution. It's not something that you can prevent. There are ways to moderate it, but it's not something that you can completely get rid of. So, does that mean that everyone's going to get PTSD? Well, no, it doesn't. Most people who experience very severe trauma, even life-threatening traumas, assaults, have a stress reaction, but this naturally recovers gradually. And we always say give it at least a month. And I think probably 3 months. Most people would give it 3 months as well. And what we find when you look at the studies on this is that about a third of people find that the symptoms don't resolve, that they persist. And most of those, I think, if they come to psychiatric attention, will end up with a diagnosis of PTSD. And it's based on a couple of things. The first is the severity of the symptoms I mentioned. The second would be their persistence, to the extent to which they're interfering with life. And the third would be their duration. So how long has it been going on for? Is it just a couple of weeks? Or has this been going on for 6 months? Because if it's the latter, then the balance of risk changes and the balance of benefit changes towards suggesting medicines, therapies, and so on. Whereas if it's the former, sometimes it's better to say, look, let's not go ahead with these just now, let's just wait and see how things go. So the symptoms become post-traumatic stress disorder when they go on for too long. So that's a very, very brief primer about PTSD. And I just want to think a little bit now about how that relates to the coronavirus pandemic. So the picture on the left of the screen is a graphic. I think it might be an electron microscope, but it's certainly a picture in one way or another of the coronavirus COVID-19 particle. And it gets into the cells of the body by latching on to the cells with those little red triangular bits that you can see. They sort of stick to the cells and the virus gets in that way. Now, you will have seen in the news that many people who get coronavirus end up in intensive care. The numbers are, it's not most people will end up in intensive care. It's only some people will end up in intensive care. And unfortunately, when you're there, your chances of recovery are not great. About a third of people who go into intensive care with COVID-19 will die. That's extremely high. So these people are extremely sick. And they're very, very unwell. Now, I'd like you to look at the picture on the right-hand side, which is, I think it's a real image, taken from Wuhan of a patient in intensive care. And you're able to see that they're surrounded by machines, which are all plugged in and will be extending plastic tubes going into the arm and the veins of the person, whether their hand or their arm or their neck. And those machines will be beeping because they need to alert the staff when they're running out. The staff themselves, you can see what that person is wearing. They're completely gowned up to protect themselves, and you can't see the human being underneath them. They look like a spaceman up to a point. Very alien environment. And then you can just about see on the, I'm going to see if I can, I can't actually get my little arrow up to move this thing, but on the face of that person that you'll be able to see, but which I can't, just about you'll be able to see that they're not actually tubed. They don't have a ventilator tube in. They've got a mask on. And that mask is a plastic mask which will sit right on the face and very tightly strapped to the face and will be blowing air into the person's lungs, a bit like putting your head out of the car when you're going at 70 miles an hour on the motorway. The positive pressure of air will be being pushed in to keep their airways open. It's something they give in ICU called CPAP. And that's 24 hours a day, 7 days a week. On top of that, these people will be full of hallucinogenic drugs and all their organs are breaking down. They're extremely ill. They're among the illest people on the planet. So it's not surprising that they have something that's called delirium as well. And BBC have spoken both about the difficulties in intensive care in general, but also in the high frequency of delirium in people who've got COVID-19. So there are two major stressors that are relevant to COVID-19 that count as very traumatic experiences. The first is a general fear for your life if you're that ill, and the second is delirium. And why? So just thinking about what delirium is a little bit more, I'm aware that some of you may know very well what delirium is. I just want to make sure that everybody is aware. It is essentially acute confusion. In other words, it's acute. It comes on suddenly over days rather than over many months or years. And it is confusion. You're not completely aware of what's going on. And what we look for in people with delirium, and I've seen hundreds of these patients, is disorientation. So in the general wards, people classically think they're on a boat. They're aware that they're in something's not quite right about a hospital. It's not the same as home. It all looks quite ordered and organised, and there are staff walking around, and a lot of these people think that they're on a boat. So they're not quite aware of where they are or what's going on. They may well be hallucinating, and that could be hearing things, or it could be seeing things. More often in delirium, it is seeing things. Or it could be misinterpreting the things that they are seeing. So you look at a common garden object, but you actually register it in your mind as something else. And sometimes those various things that I've just mentioned can go together to create delusions, which is where somebody believes something that isn't true, because they've put 2 and 2 together and got 5. And often in delirium, often but not always, these delusions are of a paranoid type. So in other words, they are unpleasant, they feel scary. The person feels as if people are spying on them or trying to do them an injury. And they're really fixed about this, they're convinced. So it's not a nice place to be. That's some of the time. Sometimes delirium can be less nasty and more benign. And I'm reminded of the story, and I have no idea if this story is apocryphal or not, but it's a good illustration of the man who came out of ICU so impressed with the love and kindness of the nun that had been standing by his bed the whole time he was in ICU that he converted to Catholicism. And only after he had done so did he realize that it hadn't been a nun, it had been an oxygen cylinder. So he had this was an example of misrepresentation. You see something that your brain interprets as something different because the hospital ward is dark, you're full of drugs that make you hallucinate slightly, like painkillers or benzodiazepines, or you may be sedated. And once you see something, it's quite hard to unsee it, right? So that can sometimes be a relatively benign course of delirium, and some patients cope very well with it. But it can also be quite scary. And the New York Times has recently written about this in an article that I've just taken a brief screenshot down in the bottom screen there, entitled, "They Want to Kill Me. Many COVID patients have terrifying delirium." I mean, that's probably a true statement, but it is probably written in such a way as to make it seem worse than it is. But some of the quotes that I've put here on this screen are from academic or scientific studies where they have interviewed people coming out of intensive care who had delirium in intensive care, and they've asked them, what did you experience? And I'm just going to very briefly, I'll read the one on the left, and I'll let you read the one on the right in your own time. But the one on the left really does illustrate something that's quite true about the experience of this. The nurses had to prepare so many patients for death, says this patient. That isn't what they were actually doing, but it's what the patient thought they were doing. They turned you into a zombie, put you on a shopping trolley and wheeled you down into a basement, and they got paid according to how many patients they brought down. Okay, so that's the 2 + 2 = 5. That patient had maybe seen a nurse wheeling someone out and had developed a delusion based on it. People were lying around at various stages of dying. I ended up in a trolley with an old boy called George who was dead. He was leaning on me, and before I knew it, a nurse came down and gave me the injection. There were people there with cloaks, like an abbot. I couldn't see their faces. They were families who would take your soul, envelop you, suck you up, and move on. I jumped out and got away, but ended up in a coffin in a chapel of rest. And so you can imagine the fear of that person living that truth. And this is the thing that's important to stress about delirium, is that the people believe it's real and there's no reasoning with them. You can't reason with them. You need to treat it with medicines. So, and it reminds me actually of when I was a junior house officer, so this would be now about 17 years ago, I saw a lady, I sat up one night with a lady in the medical wards who had a delirium, who was on strong painkillers that they were coping with her pain, but they were making her hallucinate. And she was terrified, and she sat there with the covers pulled up around her face, just looking like this from side to side all night. And I sat with her, and she told me that she could see in the curtains that were just to the right of the bed, she could see goblins climbing up, and that the curtains were on fire. And I was sitting there looking at a set of curtains. So I sat and I talked her through it, and we did what you can do in those situations, which is reorientate the person and say, listen, you're in a hospital, remember you've had an operation, you're on some medicines that are making you see things, and I'm looking at those curtains and I can't see anything there. And I think she responded to that, but other people might think that I was part of the plot and they wouldn't believe me, and that I was trying to reassure them falsely. And so it's a really terrible bind to be in this kind of situation if you're in it. And with the frequency of ICU care and coronavirus, and people on the masks that are full of breathing, I've put another quote here that was also given to somebody who was in one of these masks, not the person in the picture, but just another person in the study. So, and they talked about things including like putting your head outside the train. It was painful because the mask has poppers on the skin to keep it tight. And you get a feeling of panic if you can't breathe properly because the air is being pushed in. And that goes on all the time. And then if you take the mask off, the alarm goes off and the nurse appears and you've done it wrong and you need to put it back on again. And this person was having nightmares, sweating, panicking, after being discharged and realizing suddenly that she's not in hospital and that she's safe at home. So this person is describing post-traumatic stress disorder. So the problem that we have, and it's potentially a real biggie, is that it's looking increasingly like the people who are surviving coronavirus are experiencing very high amounts of psychological stress. Now, sometimes that's anxiety or depression, and sometimes it's PTSD. But roughly, the studies that have looked at this so far that are coming out are suggesting that about a third of patients have got significant symptoms. Now, how you define significant symptoms is a bit of a movable feast, and there will be some of those patients will actually turn out to be fine, I suspect, and will be able to go about their life. But even if half of them don't, that's still 1 in 6 people who are struggling greatly after coming out of hospital from COVID-19. And we are currently keeping an eye on this through a collaboration that I am in, along with colleagues from London and Birmingham, where every week we review the new science on the neurology and neuropsychiatry of COVID-19. So if a study comes out about PTSD or depression or anxiety or stroke or delirium, then we know about it straight away, and we're writing it up in a blog that's available, which I'll maybe get Dad to send round if anybody would like to read it at some point in the future. And this blog is on the website. It's being hosted by a journal, medical journal, and it has over 20,000 views, including from people all around the world. We've got people writing to us from Australia and Italy just this past week to say that they're reading us. So it's hopefully it will be a useful resource for people. But we know from doing this that we don't have all the answers yet. Coronavirus is too new to know how people are going to cope with it a year after. There isn't a year after. It came out in December last year. So nobody knows how people will be like a year after they had an infection, and we're not going to know that for a couple of years to come once the studies are done. But they are being done. So those are the end of my slides. And just to conclude, I talked a little bit about PTSD to explain very broadly what it is to a psychiatrist, namely an excessively long-lived reaction to extreme stress, particularly with flashbacks, nightmares, high levels of anxiety or psychological arousal, and avoidance. So in the context of coronavirus, people would avoid going back to hospital, or they might avoid going to their GP, and that could cause problems down the line. We know that having COVID-19 can be very mild. And most people, no matter what age you are, your chances are that you'll be fine after it, no matter what age you are. But there are some people, a small number of folk, who end up with a very severe form of illness that can be very stressful and scary because they're in ICU in that very alien environment. And I think the problem that we've got is that if it's just a numbers game, if you think that if a third of hospital patients are affected like this, and then you say, okay, that's over-egging it a bit, let's say it's a sixth. There are 25 million cases in the world and growing exponentially, I think, still. So think about how many, I can't do the maths in my head, I should perhaps have done them in my head, but what you're looking at least 4 million there in that relatively conservative scenario alone, 4 million extra people. So it is a big problem, and I think it's going to continue to be an issue, but we don't have the research yet to tell us exactly what it's going to be like. So on that cheery note, I will say thank you very much, and I'm more than happy to take any questions or anything else indeed that we didn't cover in the talk. Thank you again.
Thanks very much, Ali.
Stop screen sharing, Ali.
Okay, I will do. Hang on. Stop share. There we go.
Yeah. Thanks very much, Ali. An extremely interesting talk. Certainly very enlightening to all of us, I'm sure, about what PTSD is and the effects it has on people. And as Ali said, he's happy to take questions. Anyone? Philip?
We're not hearing you, Philip.
Can you hear me?
No, you're still quiet, Philip.
Quiet.
Yeah.
Very quiet. Will I move to Jim and come back to you?
Okay, Ali, when you say there are a third of patients who, do you mean who go into hospital with coronavirus, or people who are only a third of people who are in ICU?
It's a third of the studies that I've quoted are a third of people who've gone into hospital. But
That
so
is really scary.
It's a really big number. But there's a very clear, I think it's clear that it's the people who go into ICU are the worst affected. Okay. So when I mentioned that some of the third, you can probably say, okay, well, the authors are making it sound like, you know, these are really severe cases, but they might actually end up being fine. You could say that a lot of the people who are not as severely affected might fall into that category, and the ones who are in ICU might be the ones who don't.
Thank you. Heather?
Yes, that was a great talk, Ali. Thanks very much for that. I just wonder how many of the staff you may feel will get some sort of PSD.
I don't know. I know it's a big concern. So obviously, at the start of the outbreak in China and then in Italy, things were very difficult, and the staff were essentially working in the equivalent of a war zone and having to make wartime-like decisions about who lived and who maybe didn't if they couldn't get the care. And I think that will undoubtedly have contributed to their stress. But I think there is some evidence from studies that there is a higher rate of stress and anxiety in staff looking after COVID-19, but that there isn't a lot of data on PTSD as such in COVID-19, and there's a sort of a grey area between the two, because it is a bit of a judgment sometimes. Now, the staff I focused in the talk on the patient lying in the bed in ICU, but I wear that stuff when I'm giving ECT, and I can tell you it's deeply uncomfortable. You're wrapped up in plastic in a hot room, and the ICU staff can't take it off all day. They're in it all day. So I think that's a huge stress, and it is a problem, but it's less of a problem, at least in Britain, it's less of a problem than the effect on patients, we think.
Thank you.
We'll go back to Philip, see if we can hear him.
So can you hear me now? Okay. It was just one observation and one question. The observation was after my stroke, I found that 3 days on the ward I came out, and I had terrible difficulty sleeping at night for about a month or two. And I needed the light on and lots of pillows. But it distinguished itself just the way you said. After a month or two, the anxiety faded and I went back to normal. But I was interested that nobody followed me up at all after my stroke from a psychological point of view. And that was 10 years ago. So I don't know whether things have moved on. That was just the observation to say I see the difference in a stressful situation. But the question was to do with the onset of PTSD in certain people. You described it as a trauma, which to the layperson like me seems like, as you suggested, a car crash or being in the field of battle for a day or two where there's severe fighting going on. But can it be brought on over a long period of time if you've been exposed to something that's stressful that you cope with for a year or two, but later overwhelms you?
I don't know. I've never thought about that. What else would you describe it as? Well, so I think, first of all, I think some people are more prone to being able to cope with these kind of stresses than others. So that's the first thing to say. Of those who can, if someone then degenerated, I'd probably expect it was because of an event, but it might be because of the drip of it all. I'd certainly be thinking about whether there was anything else going on before I settled on the diagnosis of PTSD. So depending on the age of the person, I think, is this a depression that's come on gradually? Is this a different type of anxiety disorder that's presenting like this, not just PTSD? Or is it even the beginning of a cognitive decline? Because sometimes these people do start with anxiety symptoms that come on. But if all of those things were ruled out, I think you'd have to consider the diagnosis.
Yes, in this particular instance, it's somebody who worked for a large media organization and was pre-watching all of the traumatic video coming in over the last sort of 5 or 6 years from terrorist activities and things. And that just gradually built up and became overwhelming. And I don't know for certain, but I have a feeling he has been diagnosed as PTSD, but I just wondered whether that was rare, and it sounds like it's pretty rare.
I think, in the context that you describe, that's a pretty horrific load of things to bear over many years. And I suppose I would wonder, how was that person coping with it? Were they coping in a way that maybe wasn't that helpful, perhaps by neglecting the diet and appetite and sleep and turning maybe to drink instead? I don't know. But those kind of things can also feed into the mix, and sometimes it's not a very clean diagnosis. But I think, if you're going to, how can you say you wouldn't, under any circumstances, get ground down by that? I don't think you can say that.
Thank you.
Anybody else got questions?
Can I just...
your father's wanting to say something, Ali.
I've just wanted a question, maybe 2 questions, but I'll ask the first one first. I just wonder the effect of the lockdown on people. And whether that will... I'm not suggesting it might have PTSD effects, but it certainly might create anxiety effects.
Yeah, so it does. I think the evidence is overall, this is one of the problems with science research, is that people do studies and then they announce an overall headline, but that doesn't tell you what's happening to Jim down the street or whatever. Mm-hmm. It just tells you what happens in the whole population of Scotland when you look at the whole population of Scotland. So if you look at the whole population, levels of anxiety and depression are up. They are not at the kind of level that would cause the country to grind to a halt, but they are up. And overall, that's going to cause more impairments of quality of life and difficulty working and more alcohol problems compared to if they were not up. All right, so that's the first thing. But in my own experience, and I think this is also mirrored in the studies, there are some people who actually did really well. I don't know if any of you saw the meme for the introverts, of an introvert staring out of the window at the start of lockdown saying, "I have been preparing for this my whole life." There are people who, I have patients who have done really well, much better. They've done actually better in lockdown, and then lockdown ends and they get worse again. So some people did well with it, but others didn't. And overall, people didn't. And I think that's partly because of all of the uncertainty and anxiety in the press and everything.
Another question, I don't know if you're following the Ur Kerry Facebook page, but there's a discussion going on about wearing masks and not wearing masks. How do you get the message across to the plonkers that the consequences of this illness are so great that they really have to take every possible precaution to avoid either catching it or spreading it?
Well, you're preaching to the converted here, of course. I
never preached in my life, boy.
I don't know. I think that there's an element of you can lead a horse to water, but you can't make him drink. There's none so blind as those that cannot see. And I think there's an element of identitarianism and tribalism and identity politics that's playing out in a bigger national conversation at the moment, not just in the UK. So that's feeding into, and people having picked a tribe will not want to hear that they're wrong. And so they may just ignore you no matter what you say. But the most convincing thing that I saw were the testimonies of people who were previously of that mind and who then nearly died. and who came on and, you know, and you see them on the BBC website now and then or whatever, and they're saying, don't do what I did. There's a very sad story of a man who lost his wife to it after they had deliberately gone, you know, and it was in America, but they'd gone around not wearing masks because they didn't believe the virus was real, right? You know, because someone had written, it's been made by Bill Gates or whatever it was, that meme that was going around. You know, it's just crazy. But there will be people who believe it, and I think the only way to persuade them is either for them to get it themselves or for others that they trust, that they will listen to give them that message instead.
Thank you.
Yeah. Thanks. Karen.
Thanks very much, Ali. I really find that extremely interesting and great to hear a bit more about your work and your current research. The question I had was really to do with a comparative example, a historical one, with the pandemic of the Spanish influenza in 1918. And imagine that, there's been a lot of retrospective analysis about shell shock and that kind of thing, from serving in the trenches. But using our lens today and what we know now, whether there are any revelations from the past that might help interpret what's going on with the COVID pandemic.
Yeah, so I think, so first of all, the comparison between PTSD now and shell shock then is probably valid, but the moral valence that you put on it may not be, because there's a question over whether a culture of the present can judge a culture of the past, right, by their mode. So I'm going to sidestep that one. I think with the issue of the Spanish influenza, the big thing after it, of course, was the encephalitis lethargica wave, which swept around the world in 1920, 21, and everybody fell asleep. And the people are concerned, and I think they're probably right to be concerned, that there is going to be what's called long COVID. I don't know how many, if you've heard of this long COVID idea, but it is the informal name that's being given to the symptoms that persist 6 months down the line of fatigue, muscle weakness, poor difficulty sleeping, the sort of soft symptoms that often go along with a diagnosis of fibromyalgia or ME, and for which there are very vocal lobbies who will defend the right of the people to have these symptoms, as of course they should. But the question over what those symptoms represent is really not clear. And we know already that they're coming because the studies are beginning to report them. But the question over whether we draw a line between that and we try to learn the lessons of encephalitis lethargica and say, aha, this is a post-viral inflammatory disorder which hangs around for a couple of years and we're seeing it again, or whether we call it something else, I don't know. We just need to wait and see. It is a question that is politically sensitive because there are very well-funded lobbies on both sides. So I'm staying out of it.
Thanks very much, Ali. Great.
Thank you. Any other questions for Ali? Okay. Now, again, Ali, thank you very much for an extremely informative talk and for answering the questions that have been put to you. It's great to hear somebody speaking with sort of common or garden language that we can all understand without the medical terminology that we sometimes hear. So thanks again, Ali. I'd like the club to show their appreciation in the usual way. Thank you.
Thank you very much, everyone, too. It's great to see you all, and thanks very much for paying attention and all of the questions that you asked. I really appreciate it.